Good afternoon, everyone. We've talked a lot about sort of indications for PAO and borderline, so I try not to belabor too many points, but we'll kind of talk about the case that I'm going to present. So disclosures can be found in the meeting app. So, you know, I think the biggest point to take home for evaluation of a borderline patient is just a comprehensive evaluation. I think that instability versus impingement is something that we think about, or they can have both. So I start with a good clinical exam and history and physical, and just try to get a feel for what their main symptoms are. Here. Pain score is super critical in my practice. Sometimes that's sort of the ultimate kind of decision maker if everything else is sort of equivocal. If Baton score is above a 5 out of 9, then I'll add a PAO. This really helped me early in practice. I know this is sort of it's a very important paper for me in fellowship, but I gave this to all of my X-ray techs, and it's amazing how having a good two-dimensional image to evaluate a three-dimensional structure really helps your practice. So as Dr. Selly and other folks have said, LCA is not alone sufficient, and we need to look at other things like anterior center edge, tonus, acetabular version, also proximal femoral version, in evaluating these patients. And they can exhibit more nuanced pathology. I frequently find patients with borderline acetabular undercoverage with concomitant retroversion, which then would really point me towards doing a PAO. And also looking at rotational abnormalities, we do a full analysis. If a patient has a clinical exam suggesting a rotational abnormality, we'll get a scanogram to evaluate femoral torsion as well as tibial torsion, as well as looking at making sure whether they have labral tears or not. So the options would be hip arthroscopy versus PAO plus or minus hip arthroscopy, and I'm talking about PAOs here. So frequently in my practice, I tend to add a hip scope to a lot of my PAOs. I don't know if it's by virtue of being a sports surgeon or just being kind of entranced by the labral tears, but there's times where they don't actually have any signs of impingement, and you don't really need to do that. So kind of talk a little bit more about that. I'll skip this. PAOs are very powerful operations in this cohort. There's a lot of studies that have shown good outcomes, both from a survivorship and improved patient-reported outcomes. This is my case here. So this is a 38-year-old female with long-standing right hip pain, recalcitrant to conservative management, pretty benign kind of internal, external rotation, negative fader, no pain with sitting, but a high Baton score. So these are her images. Lateral center edge for her was 20 degrees. She doesn't have any signs of retroversion, has an upsloping sourceal, and a little bit of low normal anterior undercoverage with an anterior center edge of 23. Didn't really show a significant CAM. I measured her alpha at 54. She had a negative fader as well. I mean, one could argue that there's a little bit of flattening there, but not really that impressive. MRI showed intact cartilage and no real significant labral tear, so not overall that impressive. We did get a CT scan with 3D reconstruction, again, not demonstrating a significant CAM lesion. Her femoral anteversion was 20 degrees, so we got a scanogram. So what would you do? Just by show of hands, who in this patient would do an isolated scope? How about an isolated PAO? How about a scope PAO? A few times I did an isolated PAO. So I ended up flattening her sourceal, got her lateral center edge to the low 30s, and good anterior coverage. Managed to keep her subspine from going from a type 1 to a type 2. These are 6-month images. She's doing well, has the resolution of her symptoms. Interestingly, on this topic of non-unions, I'm a little worried about her pubic cut. However, she's asymptomatic at this time. So in my mind, I look at where in the continuum from instability and impingement they are, and sometimes they can have both. I very rarely find patients that only have instability in this cohort and no impingement, and doing isolated PAOs, but that can happen. So, as we all talked about, look at more than the LCA, look at their clinical symptoms, see what's actually bothering them rather than the imaging findings. And we do a lot more rotational assessments now than I may have early in practice. So we have a low threshold to do a femoral derotational osteotomy or tibial, depending on and or tibial, depending on their profile. So in that case, there are some studies that do show that sometimes you don't have to necessarily do any other concomitant rotational osteotomies in patients with high femoral aneurysm, as evidenced by this paper out of Ben Dome's group. That's something that we look at a little bit more. I wanted to say thanks everyone and you guys for an awesome meeting. Wanted to thank my mentors. I don't know if Dr. Wars is still here, but I was really grateful to the Boston group for teaching me what I know today, and I look forward to